Buenos días. Es un honor estar aquí. I am so thrilled to be here today, and I'm excited to talk about some of the controversies in acne. I've been studying acne my entire career. I do the clinical trials, but I'm also a medical dermatologist. So I have that unique role to be able to see how drugs perform in clinical trials and see what happens when we actually get them into the clinic. Let's start by talking about the pathogenesis of acne. We've always been taught that the first step in the development of an acne lesion is under the skin with the microcomedone. And after that, we then can develop non-inflammatory lesions, the blackheads, the whiteheads, the open or closed comedones, or inflammatory lesions, the papules, the pustules, or the nodules. But studies have shown us that that's not completely the story. In fact, when we biopsy skin that is prone to acne, before we see the microcomedone, we actually see subclinical inflammation. And after the acne lesions resolve, when we look at the sequelae of acne, we still see inflammatory molecules there. When we think about the development of scarring, we all know that nodules and cysts can develop scars. But what about the superficial inflammatory lesions? This was a study that was conducted by Jerry Tan, and he followed the acne lesions over time to see where did we get the development of atrophic scars. And it turns out it's the papules that develop into the post-inflammatory lesions, the red marks, the pink marks, even the brown marks, that are much more likely to develop into an atrophic scar. So we know that it's not just the nodules and cysts, but the superficial lesions that can lead to scarring. So now, when we redefine the pathogenesis of acne, we understand inflammation first. And if inflammation is first, that means that all acne is inflammatory acne. And when we talk about the sequelae of acne, there's still inflammation there. So we have to intervene early, and we have to continue to intervene to prevent the sequelae, the scarring, the dyspigmentation that occurs from the acne lesions. So let's talk for a minute about the bacteria that's at the center of the pathogenesis of acne, and that's Cutibacterium acnes. Is it true that they're all the same? This was a very interesting study that was done that counted the bacteria on the nose of a patient with acne, inflammatory pustules, and patients without, with normal skin. And it turns out that the number of bacteria are the same. But the difference is in the different types of the Cutibacterium acnes. So it's not the number, but it's the strains. And when we look at the diversity of Cutibacterium acnes across normal patients and acne-prone patients, we find that acne occurs due to a lack of diversity. And we have certain strains that come forward with more pro-inflammatory cytokines that create the inflammation of acne. And this was a study using mice, and it said, let's take those pathogenic strains and let's take those normal strains and inject it into the mouse. And with the pathogenic strains, we see more inflammation. With the non-pathogenic strains, we don't see the inflammation. So we have to really target those important strains of the bacteria in order to better control the acne. We also understand that the pathogenic strains are more likely to cause the biofilm. And the biofilm is like glue that allows that bacteria to hide from the body's immune system and from the antibiotics. And it allows the bacteria to thrive and to grow. And again, certain strains allow this biofilm to develop. So is it possible, and our patients ask this all the time, what can I do if I want to start to treat my acne with over-the-counter products. If I don't, or I'm not able to come to the dermatologist, or I want to supplement my acne treatments, what can I do with over-the-counter? Is it possible? Well, we have a number of acne treatments that are available over-the-counter. We have benzoyl peroxide. In the United States, we have adapalene over-the-counter. And we also have dermocosmetics. And when we look at the dermatocosmetics that are available over the counter, there are many different ingredients that help us to get the acne under control in a number of different ways. There's keratolytic agents. Some of the properties are anti-inflammatory. They help to improve the skin barrier that is defective in our acne patients. And there are some antibacterial properties that we can find in over-the-counter products. What about phylobioma? This is an ingredient that's actually derived from pomegranates. And when we look at the properties of this particular ingredient, it turns out that there are a number of anti-inflammatory, antimicrobial, including the pathogenic strain of acne, and also keratolytic actions. So it's possible to use some of these over-the-counter ingredients to either treat or to supplement our acne therapies. Phylobioma was studied, first of all, to look at the decrease in the pathogenic strain of Cutibacterium acnes, and we found a nice decrease over time. The other way it was studied was by looking at the effect on the biofilm, and again, we see a decrease in the biofilm over time. So this was a study that was done, and there are a number of studies that have been completed, but this was a study that looked at monotherapy with Effaclar foaming cleanser and Effaclar Duo Plus M. This was a multinational study of patients with different severities of acne. And they used this treatment regimen just as monotherapy without any prescription medications. And the question was, can I do anything about my acne just by using a good treatment regimen? In the United States, one of the problems we have as dermatologists is we spend so much time talking about our prescriptions, we don't talk to the patient about their regular treatment regimen, and they're looking for some guidance. So this was a study with different patients that looked at facial, truncal, and actually acne of the buttocks as well. And they asked, can we use this treatment regimen using both of these products once or twice a day over 3 months? Can we improve the acne? And what we found was, overwhelmingly, the patients said, yes, I'm able to get my acne under control in more than 7 out of 10 patients in all of these areas. And when we asked the dermatologists, they also felt that we were able to get the acne under control just by utilizing a good over-the-counter treatment regimen that happens to incorporate a number of these ingredients that we know hit many of the pillars of the pathogenesis of acne. And one of the issues we have with our acne treatments is many of them are very difficult to tolerate. They cause redness, they cause scaling, they cause stinging or burning. And we found that patients overall, by utilizing a good skincare regimen, found that this was very well tolerated. So let's now turn and talk a little bit about topical retinoids. We consider topical retinoids to be the cornerstone of our acne treatment regimen. We need them to get the acne under control. We often need them to keep the acne under control. But does it matter which treatment we use? Are they all really at the core the same? Well, we've had a number of new developments with our topical retinoids. Tretinoin was really the grandfather of topical retinoids, but could be quite irritating. We have it available in a lotion formulation that's better tolerated. Tazarotene has really been thought of as the strongest of the topical retinoids. It's available in a 0.05 and a 0.1% formulation, but only the 0.1% is FDA approved for the treatment of acne. The lower concentration is only approved for psoriasis. We now have a lower concentration in a lotion formulation that actually performs as well as the 0.1, but better tolerated. And then finally, we have a new topical retinoid, which is trifarotene. This was a drug that was specifically formulated to target the RAR gamma receptor, which is the predominant receptor in the skin. This drug was studied not only on the face, but also on the trunk. And what's interesting is, if you ask a dermatologist in the United States, should I use a retinoid on the trunk? The answer is, well, I don't know. Might not work so well, might be a little bit too irritating. And here we found that this worked just as well on the trunk as it did on the face, and in fact the irritation profile was better on the trunk than on the face. So the answer is yes, we can use retinoids on the trunk. Now what about benzoyl peroxide? Benzoyl peroxide has been around so long, a lot of people think this is old-fashioned. We shouldn't be talking about benzoyl peroxide anymore. Why are we still discussing benzoyl peroxide? But benzoyl peroxide has some very important properties. First of all, when we use antibiotics, we know you can develop bacterial resistance over time, and it can start developing very rapidly. In this study, it was really just several weeks before we started to see the development of bacterial resistance, which is the orange line. But if you use the antibiotic in conjunction with the benzoyl peroxide, the resistance was minimized. It might not be completely eliminated, but significantly reduced. And this was also tested with the fixed combination of adapalene 0.1% and 2.5% benzoyl peroxide. And with this leave-on, when they looked at strains of P. acnes that were resistant to all different types of antibiotics, yet when they used this leave-on that had a 2.5% benzoyl peroxide in it, the bacteria was killed. And it was killed starting by 2 weeks and definitely by 4 weeks. It didn't have to be a high concentration. Even the low concentration prevented the development of resistance and killed the bacteria that were already resistant to a number of organisms. What else does it do? Okay, well, we need it to help minimize resistance, but what about on its own? How much weight does benzoyl peroxide actually give to our acne treatment regimen? And it turns out that it's good for both the blackheads and the whiteheads, as well as the papules and the pustules. So it's good for all different types of acne lesions. But a question is, how long, if I want to use a wash, how long do I leave it on, and does a wash work, or do I have to use a leave-on gel? And this is a question that comes up quite a bit. Can I use a very low strength as a wash? Is that okay? Especially if you have a hard time tolerating benzoyl peroxide. And this was a study that was done in vitro, and they looked at how well Cutibacterium acnes in different concentrations was killed by benzoyl peroxide. So first, the 1.25% benzoyl peroxide, you have to have an hour contact in order for it to be killed. So is a 1.5% wash going to be okay? No. Nobody's going to stand for an hour waiting for their bacteria to be killed. So what about a 2.5%? 15 minutes. So that can be a little bit of a challenge also. But the 5 and the 10% only took 30 seconds to be able to kill the Cutibacterium acnes. This was a study that was done looking at truncal acne with a leave-on cleanser, leave-on foam versus a cleanser. So an 8% cleanser, they took the body and they rubbed it with the cleanser and they let it sit about 30 seconds and then they washed it off. And what they found was it didn't work. It didn't work. The 5% cleanser didn't work long, and it wasn't long enough to kill the bacteria. The leave-on, the 5.3% foam worked great. The cleanser didn't work. So then they found that if you put it on and leave it on for at least 2 minutes and then wash it off, you actually got good killing of the bacteria. So based on this trial, I changed the way I advise my patients. I say, first of all, I only prescribe a 10% wash because I'm worried about it killing. And then I say, put it on before you get in the shower. So when you're getting ready for your shower, put your wash on all over, wherever you want. Wait a little while. Then when you get in the shower, you wash it off. Because if you just let it breeze by your skin, it's not going to work, especially on the trunk. So does a cleanser bleach? What about the towels? So I'm going to tell you I did a very, very, very important scientific study to investigate the bleaching of benzoyl peroxide wash. I had an N of 3 patients. 2 were my twin sons, and 1 was their best friend. And based on my investigation, I say yes, benzoyl peroxide wash does bleach towels. So you have to tell them it's probably going to bleach. We have only white towels because otherwise everything turns a beautiful orange. Now, a lot of people will say, if I had my best treatment for acne, I want a topical spironolactone. That would be the best. And when we look at spironolactone and compare it to another similar agent called clascoterone, we find that both of these agents can decrease the production of sebum. Yet when we look at the anti-inflammatory properties of clascoterone versus spironolactone, clascoterone is actually more anti-inflammatory. So clascoterone is the drug that went forward for a topical formulation. And this is a drug that competes with dihydrotestosterone at the level of the sebocyte. And with this, we see a decrease in the production of sebum. We also see a nice anti-inflammatory profile. This drug was studied in clinical trials where I was fortunate to be an investigator. It's a twice daily treatment, and we studied it over the course of 3 months as monotherapy. And what we found was this drug got about 20% of patients to clear or almost clear, and it worked for both the comedones as well as the papules and the pustules. The other thing we found was the irritation profile was actually very mild. It was well tolerated. Now, in the package label in the United States, clascoterone is associated potentially with elevations of potassium. You don't have to check a potassium level, but it's in the label. So we did a deep dive into all the studies with clascoterone to find out what do we know about this potassium abnormality. And it turns out that it was the children, the 9 to 11-year-olds, that had point elevations in their serum potassium, but this was not clinically relevant. And in the United States, it's actually not approved unless you're 12 or up. So it's something that's been described, but we really don't worry about it. We do have a new triple combination that's been FDA approved in the United States. And when I first heard about this, I said, oh, please. Why do I need a triple combination? I have these drugs already. I have adapalene. I have benzoyl peroxide. I have clindamycin. Why do we have to put it into one tube? Well, I was surprised, and sometimes I'm humbled, when I say this is not going to show much difference between any of the 2 ingredients. It certainly will be better than the vehicle, but is it going to be better than the adapalene and benzoyl peroxide, the benzoyl peroxide clindamycin, or the adapalene clindamycin? How are we going to show that the triple is better than any of the 2? And the answer was, it was. It was not only statistically better, it was almost synergistically better. And each of the individual ingredients really shined. Each of them pulled their own weight in getting efficacy. And when we went to phase 3 clinical trials, we found that over half of the patients, or up to half of the patients, got to clear or almost clear. In terms of treatment regimens, this is the highest efficacy of any of our acne treatment regimens except for oral isotretinoin. So let's talk for a minute about oral antibiotics. Does it really make that much of a difference? I was involved with the acne treatment guidelines in 2016 and then again last year, and we certainly still recommend the use of oral antibiotics for the treatment of acne. Only doxycycline got the highest level of recommendation, and that's really because it's not expensive and the side effect profile is manageable. Minocycline got a conditional because it's associated with some significant side effects, and sarecycline was conditional because it's expensive in the United States. And when we look at the difference of adverse events across the tetracycline family, we see there's certain things that are true across all of them. GI upset, photosensitivity, resistance. We don't use any tetracyclines in patients who are age 8 or under because of the possibility of staining the teeth. Pseudotumor cerebri with any of them. But there are certain things that are really specific for minocycline: vertigo, skin hyperpigmentation, autoimmune hepatitis, hypersensitivity syndrome, and drug-induced lupus. We do have a newer antibiotic called sarecycline, and this drug was actually made for a number of specific reasons. It has this C7 moiety that was added, and this helps the antibiotic to overcome the development of resistance. So when it comes into the cell normally wants to pump it out really fast. Comes in, it pumps out. But this dampens that so the antibiotic stays within the cell for longer periods of time. It also has a narrow spectrum of activity for gram-positives. So we see a decreased level of resistance. We see a higher level of anti-inflammatory properties. And one of the studies that we did was we looked to see if sarecycline crossed the blood-brain barrier. And we compared it to minocycline, and we found we know minocycline does. That's why you get dizzy and headaches, but sarecycline doesn't. And that's why we had a low incidence of CNS side effects in the clinical trials. And using this as monotherapy, we found that it works well both on the face as well as the trunk in getting patients to clear, almost clear, and also for the papules, pustules, as well as the comedones. I'm going to conclude by just talking for a minute about oral isotretinoin. This is a drug that's used tremendously by the dermatology community. It's one of the best medications that we have. It's given very high levels of recommendation by the acne treatment guidelines. So some of the questions that come up surrounding isotretinoin is, should I use this in conjunction with an antihistamine? And a lot of people say, I think this is a good idea, but there haven't been great studies that have looked at this. This first study looked at 50 patients treated with isotretinoin alone and 50 with the combination therapy. And they found that it did seem that the antihistamine increased the efficacy a little bit, so that was possible. And then there was another study out of North India that looked at low-dose isotretinoin with or without antihistamines, and they found that there was no real difference in efficacy, yet the dropout rate from the study was lower in patients who used it in conjunction with an antihistamine. So it might be, for some patients, it might be worthwhile. What about the issues with inflammatory bowel disease? Years ago, this was a very, very big topic in the United States. Lots of lawsuits for Crohn's disease, inflammatory bowel disease, ulcerative colitis. We've had a lot of studies, but we give some conflicting results. This was another recent, very large study that found there was an increased risk of inflammatory bowel disease in acne patients, but not an increased risk with tetracycline-type antibiotics, and not an increased risk with isotretinoin. So it's the acne and the inflammatory bowel disease that seem to be related. And what about psychiatric disturbances? We certainly worry about this with isotretinoin. This, again, was a very large study, and they found that the only thing that was associated with an increased risk of isotretinoin was suicidal ideation. But the things that were decreased, suicide attempts, depression, PTSD, anxiety, bipolar disease, schizophrenia, all these other issues were diminished. So the bottom line is the future is very bright. Our acne patients need us to continue to help them to feel healthy and good about themselves. And fortunately, we have a number of great tools to help them get there. So thanks so much.
Muchas gracias, Linda.